Hey y'all, it's Shelly with Shelly's Nursing Review and Health Education Television, HETV. This is our final video on sickle cell anemia, and as I stated when I started this series, that all of my videos going forward are going to be in the format of using the clinical judgment as the backdrop, because you know that clinical judgment is what they're testing for on the new Ngn Nclex exam, right? So you have 6 parts to clinical judgment. In the first 2 videos, we covered recognized cues and analyze cues. The video before this one, or part 3, we covered our, out of the 6 part model of clinical judgment, we covered number 3 and number 4. Number 3 was prioritize hypothesis, number 4 is generate solutions. On this last and final part 4 of the sickle cell anemia, we are covering our final 2 parts of the clinical judgment model: take action and evaluate outcomes. So let's get started, but let's give you love. In the last video, like I always say, I always forget you guys, but you know me, I come back around. So I want you to make sure you call, well, not really call, because I ain't gonna answer the damn phone anyway, but I'm saying text 216-410-0936 or email CHELLYS NCLEX PREP at gmail.com if you want me to go ahead and send you your complimentary copy of the best NCLEX study guide on earth. It has everything in here. It's got pharmacology, it's got how to do the case studies, it's got test taking strategies, it has your cultures, your ethical legal is in here, your diets and your positions, your pediatric and maternity quickies, your select alls for neutropenic precautions, bleeding precautions, seizure precautions, infectious disease. I mean, it has everything in here. It's got your, it's even got your intracranial pressure, like neuro type stuff. It's got all your shocks. It's got labs. It's got how to prioritize. What should the float nurse do? It's got in here how to delegate. It's got all of the people you should be seeing first. It's got what to avoid when you're answering questions. It's got a prescription for how to pass the NCLEX, a description even of my mastery program that has made me #1 in the country. All right, so come on now, get off your butt and text me, or if you prefer, email me. Now I'm gonna erase these. Hopefully my girl got like a good shot, because we got shit to do, you guys. Like, I gotta get out of here, for real though. Okay, here we go. All right, wham bam, thank you ma'am, let's hit it. Now, so as we venture forth with our sickle cell disease, I want to again read to you something very pertinent with regards to what just happened that was exposed in the media for a sickle cell anemia case study, if you will. So this is a real live case study. In other words, I looked at all the reports on this case study. I tried to keep it as accurate as possible, given that the media has, you know, a tendency to get shit wrong. So I looked at least 7 different sources for this information about what happened to this child in custody who had sickle cell. So I'm gonna read to you some things, and you're gonna see how when you look at all the videos, this plays out completely. So here we go, real life case study. An 8-year-old, oh wait a minute, let me quit playing it off, like for real, like I ain't trying to, you know, perpetrate. My ass is blind, and I'm here to tell you, it is what it is. When you get old, you better hope you get blind and not dead, okay? I'm damn near 60, I look good, I feel good, but I'm blind, okay? I'm just saying. Whew, glad I got that out the way. 8-year-old Honduras female presented with flu-like symptoms while in custody at a migrant holding facility in Texas. I just gave you 1 sentence, and right away your little ass should have picked up on about 3 different things that sickle cell is going to be a real problem. Number 1, you know when they say an ethnicity on your test, that it means something, because nothing is going to be wasted on NCLEX. And while this is not from NCLEX, this is from Real Talk, Real Life, just happened in May. This tells you something about this patient. She's Honduras. What did I teach you? Latino, African American, Caribbean, and African. That's who you should be thinking about when it comes to sickle cell. She presented with flu-like symptoms. Why do you give a shit about that? Because one of the number one triggers of a sickle cell crisis is an infection or fever. She was in custody at a migrant holding facility in Texas. Why do you give a shit? Because Texas is hot as hell in May. So now we have another trigger, extreme temperatures. Okay, I'm gonna keep on going, y'all. The family arrived at the facility on May 10th. A medical assessment was performed, and at that time, the family shared that their daughter had a history of sickle cell anemia and a congenital heart disease. So you already know what it is. She told you what it was. The patient had sickle cell. Now, this child complained of abdominal pain, had a cough, congestion, and a fever of 104.9 for a period of 3 days from the evening of May 14th through the afternoon of May 17th, and was seen at least 9 times by medical contractors. So what we got? Abdominal pain, classic sickle cell. Cough, congestion, fever, high grade. So we have evidence of an infection, but we also have evidence that if this is not handled quickly, we might have more sickling, because a high-grade fever requires that your body uses more oxygen because it increases your BMR, or your basic metabolic rate. And so this high-grade fever of 104.9, oh my God. Okay, y'all stay with your girl. Her history includes sickle cell anemia and a congenital heart disorder, and the parents brought documents outlining their daughter's extensive medical history, but they were not actually reviewed by the medical personnel contracted to provide the care or those who interacted with this sick child. This child tested positive for influenza A, was diagnosed with the flu and a fever, given Tylenol, and here we go. The straw that broke the camel's back was they gave that poor precious child ice packs and gave her a cool shower. The worst thing you could do to a sickle cell patient is give them freaking ice packs and a cold shower. They basically accelerated her death, okay? Numerous parental requests for an ambulance to the hospital were denied by the nurse practitioner. Now I need you to think just one damn minute. Just remember what I said. Sickle cell is a chronic condition that has acute episodes of crises. So if you a mama or a daddy and your baby got sickle cell, you already know what to expect and how it is going to be if it's getting worse. So mom over there begging for an ambulance, these motherfuckers ain't doing shit. I'm getting mad about a minute, so let me just try to finish this shit up. Woo! On May 17th, this child was seen, count them, 1, 2, 3, 4 times by the nurse practitioner for difficulty breathing. Can we say hypoxia, please? Do you think they gave that child some damn oxygen? Hell no. Okay? For difficulty breathing, stomach ache, and nausea. Reportedly, I just want to say that word, get a little close to you. I know I ain't looking my best. I need my hair done. I'm looking like a hot ass mess, but I just want to say that word close to you so you can see my face. I said reportedly. You know what that means, right? It means somebody lied. Here we go. Reportedly, this 8-year-old had a normal heart rate and a normal blood oxygen saturation at each of them 9 visits. On 5/17, so we're now in May, we're now on May 17th, it's 2 o'clock. Remember, this child been seen over 3 days. Now it's May 17th at 2 o'clock. We started this bullshit on May 14th. Now it's 2 o'clock in the afternoon. Mom has returned to the health unit for the 5th time, you following me? This time holding her daughter, who appeared to be having a seizure. You damn well better believe she had a seizure. You know why her ass had a seizure? Because she had a damn temperature of 104.9. If that's not high grade, I don't know what is. And if you don't remember that children with high grade temperatures can absolutely seize, then I don't know what to do with you, because that's a whole nother class. So mom brought that baby in for the 5th time. Now we look like we're having a seizure. Soon thereafter, this poor baby became unresponsive. CPR was started. The child was taken to the hospital and pronounced dead by 2:50 p.m. So 2 o'clock, she brought her baby in there for the last time. They sent that baby to the hospital, and by damn near 3, not even 3 o'clock, she was dead. Upon an internal investigation, it was determined that the nurse practitioner did not consult with the on-call physicians or the on-call pediatrician. Numerous encounters with this family, the fact that emergency antipyretic interventions and administrations of medications that were given was not documented or disclosed. And that's a case study. That's a real case study. So let me try to get your behind not to be that nurse and get you over here so that you can even intervene when you get a doctor or a nurse practitioner not cluing into what's going on with this baby or adult. Okay, so here we go. Chop, chop. We're taking action. Come on over here with me so you can take some action. Here we go. What we doing, y'all? Because we had a plan of care. Y'all remember the plan of care was hydrate, treat the pain, blah, blah, blah. How you gonna hydrate? You need an IV ×2. Why ×2, Shelly? Because I damn sure hope you realize that this patient during their hospital stay could need some blood transfusions, because sometimes the only way to treat sickle cell is to give a blood transfusion. So we got IV ×2. What gauge for adults? 18. What about that baby? 24. Remember, the higher the number, the smaller the needle. That 8-year-old would have got a 24 gauge, or even 22, but 24 is most likely, because she was already tiny, because this sickle cell distorts your growth, delays puberty, it does all of that. So that baby, when you look at that baby, and hopefully you will look at that baby, because it's all over YouTube. If you see that little 8-year-old baby, she look like she's 4. Because it, you know, again, sickle cell, it's going to delay your puberty, it's going to stunt your growth, it's going to do all this shit. Now, so IV ×2, 18 gauge, draw your labs at that time. We're taking action. We're hydrating with an IV bolus. We give an IV pain meds. Look at where I'm going now. Either through PCA, patient-controlled analgesia, so y'all don't treat them like they're drug seeking, like has happened in the past. And you're doing these drugs, these opioids, these medications, you're doing IV pain medicine for at least 48 straight hours around the clock if it's not a PCNA. I mean, if it's not a PCA. You might, let me say that again, because I bet that's going to show up again. I said IV ×2, because you're probably going to need to give a blood transfusion. These are 18 gauge angiocasts that you're starting the IV with. You're drawing labs at the time. You got plenty of labs to do. You're making sure this patient is hydrated with the IV bolus. That was the whole reason why you got the IV started yesterday, so you can get this baby IV bolus. You're giving this patient IV pain meds times 48 straight hours, preferably in the form of a PCA, patient-controlled analgesia. All right, moving on. You are administering oxygen, PRN, for SpO2 or pulse ox less than 95. You anticipate orders for a chest x-ray, urinalysis and culture, sputum culture, blood cultures, ABGs if the patient's having problem breathing or their pulse ox is low, and a lactate if it looks like they got a fever and might be septic. Y'all all right? Good. Because here you're working up the fact that infection is one of the #1 triggers of a sickle cell crisis. The blood transfusion. Now, I ain't got to tell you about no blood transfusion. That's a whole nother video. But let me just remind you that if we do need to give this patient some packed red blood cells, which is going to dilute the sickle cells out and give you fresh, normal cells, right? Remember, they often have an order for blood transfusion, but you have to make sure that you check for that order first, and then check that consent before you do any of this other crazy stuff you got to do to prepare for a blood transfusion. And I do want to tell you that these sickle cell patients, they get so many blood transfusions that literally they are very apt to have positive antibody screens and very apt to take a long time for the blood to be ready. So if you're smart, on admission, you will ask that doctor or nurse practitioner, hey, you want me to go ahead and type and cross this patient in case they need some units of blood, or type and screen? Because a lot of them don't even get to type and screen. So you definitely want to go there with the doctor or the nurse practitioner. You want me to go ahead on and boom, get that type and screen in case you need a blood transfusion? They're going to be impressed and you're going to be ready, okay? These patients are put on folic acid, but don't get it twisted. Folic acid is really vitamin B9. Do not give these patients iron. I don't care who ordered it, they do not get iron. It's contraindicated, it can cause toxicity and a stroke. They are going to receive opioids already. They get the IV pain meds for the first 48 hours. Then we taper them down to the PO, because you can't go home on IV. You got to take your butt home on PO. And they're used to PO. They usually have it at home. Guess what else works really well? NSAIDs. Now, I know you don't really see a lot of NSAIDs ordered for the hospitalized patient, but keep in mind, this patient is not elderly, which is when we frown on NSAIDs. This patient is usually young, and NSAIDs work wonders for their pain. In addition to the opioids, it's a nice little bridge to the next opioid dose to space the opioids out as we get on top of their pain. In addition to that, the NSAIDs has a topical. Let's hope you remember what the topical is. It starts with the D. She loves the depot. Diclofenac. Lovely, lovely little topical. You just put that little diclofenac cream on that patient and their joint areas, their knees, their elbows, and they feel better. And then we also have topicals called, this is a topical, but another topical that works really well for these patients at times, it just depends on the patient, could be lidocaine, patches. You have to be careful though. I'll tell you why you have to be so careful. If this sickle cell patient has any kind of kidney disease, you can't be using no NSAIDs. You know damn well that NSAIDs are contraindicated in kidney disease, okay? So be careful now. Know your shit. Don't just throw stuff on people and not know what the kidney function is. Check the creatinine and the BUN. Okay, now the antibiotic prophylaxis, while you take an action, more likely this patient will be given IV antibiotics because infection is very often a trigger for sickle cell. But if it's not, because they have no infection, they will be given antibiotic prophylaxis. And what I've seen in my travels, and I've been traveling, is these patients get penicillin BID. So they either get penicillin or some Cipro or something, and they're gonna be on that for a minute. Okay, that's what they regular is. Before they came here and after they leave, this will be called antibiotic prophylaxis. Don't be surprised if the patient is scheduled for DVT prophylaxis in the form of heparin shots. Now, that's one thing, but you ought to know something about preventing the DVT as well. Once you make sure that the patient is not hypoxic or having all kinds of drama, you want that patient moving as much as they can once their initial crisis has settled down so that we can prevent this blood clot, because it is very real that these patients are at risk for DVT and PE, because as you know, all PEs started out as a DVT. You remember your HHOP, okay? H for hydroxyurea. This H for hydration, and then this one for hydration, this one for hydroxyurea and heat, keeping the patient warm, oxygen and opioids, pain relief. And so we have a few meds that we might be using. Hydroxyurea, we have a couple other meds, some newer meds that are out too. There's about 3 good medications for sickle cell, and I'm gonna list them up there when we're all done. Now, vital signs, I want you to remember something. For this patient, very often we tend to put automatic blood pressure cuffs on patients, not even thinking about it really. And the automatic blood pressure cuffs can be super tight and really, really hurt. Any kind of restrictive clothing or blood pressure cuffs like that, you don't want those. You want to avoid those when you're doing their vital signs, because they really can cause quite a bit of problems, because you're causing more sickling. You're causing a vaso-occlusive crisis, putting that damn tight ass cuff on that patient. Now, the basic care and comfort or alternative therapy, I want you to remember warm compresses. I want you to remember antipyretics. I want you to remember aromatherapy. I want you to remember distractions, Reiki, therapeutic touch. I want you to remember the pet therapy. I've seen my patients have music therapy, and you know, just whatever you can, positioning, repositioning the patient, keeping their extremities extended, not flexed, because it's during the flexion that the sickling occurs around those joints. Whatever you can do to help this patient get through this painful situation, right? And so then if you look at the take action, the last step is evaluate the outcomes. Now, I think you get this, but let's just make sure you get it with the sickle cell. When you're evaluating this patient, they've got frequent pain assessments. Why? Well, because if at any point their pain includes chest pain, we're going to have a problem. Let me explain. I have a student. Her daughter was 5 or 6 years old. She had sickle cell. She came into the class because class starts at 9. She got a call from the daycare or whatever that the baby was sick. She took her daughter to the hospital. She said they arrived there about 10:30. They were getting triage and getting in a room and the whole thing and how long that takes. She said by a quarter to 1 o'clock, her daughter said, and I quote, "Mommy, my chest hurts." And she was dead by 2. I need you to know that when you admit this sickle cell patient, your attention, your expertise attention to chest pain is huge. Acute chest syndrome is the #1 cause of death in the sickle cell patient, whether it's a child or an adult. So I need you to evaluate signs of worsening condition like chest pain. You're looking at the vitals. Did the temp go up high? Did the pulse become tachycardic? Is the blood pressure dropping? Is there possibly sepsis going on in addition to the hot ass mess, right, with the sickle cell? What's going on? Monitor them labs. Is the white blood count going up? Oh no. Did you check all them cultures that you bothered to do, like the urine and the blood? Is it growing anything? What's going on? Did you run that typing screen? Is it back yet? Because we could need a blood transfusion. Does she have positive antibodies, like, because she's had so many transfusions? I mean, our hospital, they'll tell you right up front, listen, if you think you're going to need a typing screen, you better send this shit early on these patients because it could take 2-3 hours to get units of blood. Seriously. Okay. As the candidate starts to feel, as the patient starts to feel better, and we're getting closer to where, okay, look like she might go home tomorrow or the next day, and you see that she's been frequently admitted over and over again, you know, there should be some conversation about, especially with children, possibly this patient being a candidate for a cure. A cure? Shelly, sickle cell has a cure? You damn skippy, it has a cure. What's the cure? Stem cell transplant. Now you may be thinking, well, why didn't I hear about that in nursing school? Let me help you with this. It's been my experience, and it's a fact, that cystic fibrosis, which is exactly like sickle cell in terms of it being an autosomal recessive genetic disorder, it has received more attention, more research dollars, more expertise than sickle cell ever has. And sickle cell has been out the longest, okay, in terms of discovery of diseases or whatever. And it affects way, way, way more people. But you already know what that is, right? You know, it's called disparities in healthcare. It is what it is. So I say that so that you understand, for this patient to get the cure, we're going to talk about haves and have-nots. Even for the medications, I know the one medication was, I think it was anywhere between $1,200 to $1,500 a month, and it's not covered by insurance typically. To get a year's worth, it's $24,000. Okay, so you know, haves and have-nots matter. Well, to get a stem cell transplant, you need a referral. They say you need a brother or sister, sibling of some sort, to donate. They talk about the fact that if you can't find a match, it is what it is, even though we find matches for kidneys and everything else all day long. Okay, so you know, work with your girl. And so I use this opportunity to bring up something that I used to do as an OBGYN nurse midwife. I used to take the cord blood per the patient's, the family's orders, right? The family wanted to save the cord blood. I used to take the cord blood from their precious new life, this child that I just delivered them. I would take the placental cord blood and we would save it, and that cord blood can be used for this very reason, stem cell transplant. Now, I got to give our hospitals in Cleveland some big ups, because when I used to deliver these babies and save the cord blood, it was always my wealthy patients who could afford it. Because I think it was at the time, it was like $1,500, $2,000, $800. And none of my poor patients could afford it, of course, whether they were white, black, purple, or blue, or whatever. They couldn't afford that, right? And so our hospital, one of the #1 hospitals in Cleveland for delivering babies, University Hospitals, took it upon themselves to say, now wait a minute, I tell you what, we're going to save the cord blood on every single baby that's born and put it in a public banking system to help families whose child has conditions like sickle cell obtain a match, possibly, to cure their disease. My God. I tell you, it's philanthropy like that that makes me want to cry, because I don't have sickle cell, but I know a million people that do. And the very thought of them affording a stem cell transplant or cord blood saving, cord blood procuring and saving, it's not going to happen. It just ain't. Okay. All right. Now, so you're going to be, kind of interested in that, just in the periphery. Now, you're going to check the medications that we use to decrease the sickle cell crisis. I have a student who had sickle cell. She was a whole nother student that also had to call her doctor and tell them to take her off estrogen-containing birth control, because I told her I think she should talk to her doctor about it, because typically we do not give our patients that, and she needs to consult with her doctor. And she did. They took her off. They gave her the regular progesterone. But before they gave her that progesterone-only birth control, my student, my baby, was in the hospital repeatedly with sickle cell crises and, get this, DVTs. I wonder why. Could it have been that estrogen? Interesting. So once we told her, you ain't got no business with the estrogen. Call your doctor, talk to him, fire him, whatever you got to do. They took her off the estrogen. She didn't get any more DVT. She had been in my class for 3 years because she was always in the hospital with a sickle cell crisis. When she finally passed her NCLEX exam and got her first job at, I might add, University Hospitals, when she went to University Hospitals to get this job, she now had insurance, because before that she didn't, because wasn't no Obama back then. Yeah, Obama came out later with his Obamacare, because she definitely would have qualified. She was poor enough to get it, and she was a working poor. Don't get it twisted. The people who have no insurance are the working poor, not welfare moms and all the rest of the shit that people would have you believe. No, people who are uninsured are usually the working poor. So that's what she was while she was in school. She was a working poor, had no insurance, finally gets her brand new job, gets insurance, calls me up a year later crying, telling me how she was finally authorized to get, here we go, hydroxyurea medication. She said that she went down from an average of 14 crises a year to 2. And she wanted me to know that she thanked me for providing her the knowledge about hydroxyurea, because before we brought it up in class, no one else did. Not no doctors, not no nurses. Now, this hydroxyurea was expensive as hell. It's now generic. It's generic. So we good. We definitely good. But there are other medications, they're not generic. And I don't want to spell them wrong, so y'all bear with your girls. So here's the 2 other medications. They're not generic. They're going to cost you an arm and a leg. One of them is L-glutamine. This is the bad boy that is about $1,500 a month, so you can imagine, but it does work really well. It decreases the frequency of pain and sickling crisis. It also extends the red blood cell lifespan, so it makes your red blood cell live longer. But again, shit is expensive. Let me give you another one, and you'll notice something about the one I'm about to write. I'm going to erase hydroxyurea, which is a wonderful drug. It was used for chemotherapy, and now it's used for the decrease of sickling. Here's the other medication, CHELLYS Analyzer. Ooh, honey. Analyzermab. Now, I don't really care about this drug over here. I care that you notice what I wrote over here, because I taught you that drugs that end in MAB, that means monoclonal antibody. Now, it's a wonderful thing that this drug also will decrease the number of sickling episodes, but it's a once a month infusion, like most monoclonal antibodies, once a month infusion. And with any monoclonal antibodies, you usually have to premedicate the patient, because these meds give you a fever, flu-like symptoms, back pain, joint pain. You know, you just don't feel good. So it's a good idea to premedicate our patients with Tylenol or Motrin or something, so that when they get these medications, they don't feel like shit, right? Sometimes we give them like Benadryl, steroids. I've given Benadryl, steroids, Tylenol, or Motrin for pre-medication of monoclonal antibody infusions, okay? So it's just a little whet your appetite, kind of letting you know that there's more than hydroxyurea out here to decrease the amount of sickling crisis episodes. That's important to you on a test somewhere, okay? All right, now, so that's the meds. So as you're evaluating this patient, you're also remembering that for some of these patients, this is their first experience with this situation, this genetic disorder. They will need genetics counseling, especially childbearing age women, okay? You're monitoring this patient while they're in your care for fever, for hypotension, making us think maybe they're going septic. You're also monitoring for hypotension because they can get kidney failure behind that. So you're looking at the oxygen levels. You might even need the ABGs or whatever. You're monitoring those labs, lactate, ABGs, the cultures, what were the results. You're monitoring here. Let me help you with this. Every crisis that the patient experiences is damaging their organs, in particular kidney function. It is not uncommon for this patient to be in their 30s and 40s with some kind of chronic kidney disease because of so many repeated AKIs, okay? So it's even more important for you to know that a low blood pressure will kill a kidneys. What do we say? No BP, blood pressure, no PP, urine, kidney function, okay? No BP, no PP, no BP, no PP. So keep the blood pressure up, keep the kidney function going. You got to know that, okay? Now, neurovascular checks just has to do with capillary refill, comparing pulses in both the legs, making sure that the vascular system is intact and there's no ulcers on these inner ankles. You know what I taught you, right? Patient teaching about prevention. Then annual flu and pneumonia vaccines. Update all their vaccines because that will cut down on infections. But let me talk to you about that teaching. You might remember that I've left, you might have peeped this, that I've left these damn triggers up here for every single board. Why? Because if you know the triggers, you know how to prevent the crises in the first place. This patient needs to stay hydrated 4 to 5 liters a day. No, I lied. 3 to 4 liters a day. Now, I want to put that in perspective because some of y'all is precious. You know, you be having precious moments when I talk about liters and shit. So let's do 2 liters, which is what you and I should drink. How many bottled waters is that? That is actually 4 bottled waters. And I want you to know that. So if I told your ass to drink 4 liters of water, you'd need 8 bottled waters. Okay, so that's how you gotta talk to your patient. Your patient don't know what the fuck a liter is. Talk to people like they got some sense now. Quit making it all up in here when you know your patient is down here with you. Quit it, okay? Prevention of infection, frequent hand washing, avoid crowds, avoid sick people, keep your vaccines up to date, all that. Anything you think you got going on, go see a doctor yesterday, okay? Take your antipyretics for this fever, all right? Avoid extreme temperatures. Stay the hell out of Alaska, and your little ass don't need to be down there by the equator either, unless you're in air conditioning. Stay off the airplanes. What you doing? You better get in a car somewhere. Exertion. You can't do boot camp. You're not finna run a game of basketball. You're not finna go out here and act fool and do some tennis. No, you better sit your ass down. Or here's something you could do. Baseball, because it's just one little spurt of running. Bicycling. Don't get it twisted. You can't get lazy and sit on your ass. No, I didn't say that. I said you need to avoid the extreme exertions. Basketball and tennis and all of that, that's extreme exertion, okay? Why is you doing P90 eggs and all this here hot mess? You're crazy, okay? Now, we know if you need surgery, that anesthesia is going to have to be notified, and you need a consult early on to prevent some of this hypoxia that is going to trigger a sickling event. So surgery and anesthesia are taken very seriously. Trauma, it is what it is. We hope you don't have any, but we know trauma is a trigger. Pregnancy, you need preconception counseling before you get pregnant so we can optimize this pregnancy. Make sure we deliver you a beautiful child. No estrogen containing birth control. Stay the hell off that Hennessy. It is not helping your sickle cell. And why is you smoking Black and Milds, fool? Okay, now, acidosis and venous stasis, you already know what that is. Okay, you know what? I'm tired. I'm real tired. I'm real tired. I'm about to be gone because I gotta go, okay? I gotta do my budget for the month. Gotta do my, what did I do? What did I say I had to do earlier? I gotta read my Proverbs. You reading Proverbs, ain't you? You get 1 Proverbs a day. That's why God gave you 31 Proverbs. He covered the longest month in the year. Deuces.